A very good morning to all and welcome everyone. It gives us great pleasure to welcome you all this beautiful morning. Thank you for joining us today. We are very excited to have you here on behalf of Sri Balaji Dental College and Hospital, which has taken an initiative to bring education to you no matter where you are. At the onset, this TMJ Masterclass will happen on the last Sunday of every month, and where we will be having an opportunity to learn from various speakers on various concepts and expand our knowledge on the subject. I take this opportunity to thank our speakers and our panel who have gathered here today for taking their time to share their knowledge and their perspectives on the subject. I would also like to thank our principal, Dr. S. Jimson, for his persistent efforts in bringing various opportunities for the welfare of the students and delegates. On that note, today we'll be discussing intricate aspects of the temporomandibular joint and will be giving you practical tips so that you can put to use in your practice. We'll also be taking questions throughout the webinar, so please feel free to type them in the Q&A section and as well as in the chat box. And now, without further ado, I request our principal, Professor Dr. Jimson, to say a few words and kickstart this program. Thank you.
Thank you, Dr. Nikita, for that wonderful introduction. On behalf of Sri Balaji Dental College and Hospital, Department of Oral Maxillofacial Surgery, we invite you to be part of this initiative, the Temporomandibular Joint Masterclass. As Dr. Nikita mentioned, we'll be having a series of webinars throughout the year or for the next 12 months or so. It will be the last Sunday of every month, barring November, where we'll have our EMSA National Conference. And I would like to thank all the speakers, the moderator, and the mentors of this program, Dr. Kannan Balraman, Dr. Nehal Patel, Dr. Abhay Kamath, who has kindly helped us in the build-up of this TMJ Masterclass. I'd also like to thank the ISTMJ's group, where Dr. Nehal Patel is a secretary and Dr. Neelam Andrade is the president. Also, I would like to thank the AMSI Tamil Nadu Puducherry branch, Dr. Arun Kumar, the secretary, and the president, Dr. Subramanian. And without the help and support of our management, I don't think this is possible. And I would like to place on record the consistent support from our chairperson, Dr. Srinisha, for this endeavor. Without taking much time, I think let's get started. The participants have already joined, and Dr. Kannan here, no, is yet to join. And it is my privilege to introduce the moderator of the day, Dr. Satish Kumaran, who is the head of the Department of Oral Maxillofacial Surgery at B.R. Ambedkar Dental College, Bangalore. He did his master's at Savitha Dental College, and he went on to finish his fellowship at UK. Welcome, Dr. Satish. Program moderator session. And the panelists include a senior professor, Dr. M.R. Muthusegar, who is a professor emeritus at Savitha Dental College. He has got more than 35-40 years of experience in oral maxillofacial surgery, and he has been a mentor to many oral maxillofacial surgeons who are present throughout the globe. The next panelist is Dr. Chitra Chakravarti, who did a master's in oral maxillofacial surgery at Manipal Dental College, and now she's heading the department at Dental College in Karnataka. And she has authored a textbook on oral maxillofacial surgery as well, and she's a much renowned speaker. She has lectured in various national and international conferences. Welcome, Dr. Chitra Chakravarti.
Thank you, sir.
Dr. Jagdish Chandra, who's the head of the department at Yenapoya Dental College, and he again requires no introduction. He is a academician par excellence, and he is again got many publications to his credit, and he is a wanted speaker in the national and international arena. Welcome, Dr. Jagdish.
Thank you, Dr. Jensen.
And Dr. Arun, who's the secretary of our state association, oral maxillofacial, AMS Tamil Nadu Puducherry branch, who has been an active surgeon and is very active as a secretary as well. And he is a professor at the Tamil Nadu Government Dental College, Chennai. Welcome, Dr. Arun.
Thank you, Dr. Jimson.
Over to you, Dr. Satish. Yeah.
Thank you, Dr. Jimson. At the onset, I'd like to ask everyone if I am audible. Am I audible?
Yes.
Thank you, sir. Thank you, sir. I'd like the management of Sri Balaji Dental College and Hospital, and especially Dr. Jimson, for giving me this opportunity to moderate this session. It is my privilege and honor to be moderating this session because, on a more intimate note, my mentor and teacher, Dr. Muthusekar, is here, and a wonderful session panelists. Without more delay, let us move on to our topic. The topic for this morning session is temporomandibular joint anatomy and the biomechanical aspects. A brief note on the temporomandibular joint. It is an enigma, and for most of our colleagues in the other medical fraternities, the temporomandibular joint is a mystery. And we as oral surgeons have a large advantage in operating on the temporomandibular joint. Therefore, the understanding of the joint and the associated structures of the joint are of paramount importance to us. Temporomandibular joint disorders are a heterogeneous group of musculoskeletal and neuromuscular conditions. It affects most of the adults in the young age. They can be classified as whether they are inside the capsule or outside the capsule, which is intra-articular and extra-articular. They are multifactorial, which is why it becomes extremely difficult to treat temporomandibular joint disorders. They have biological, environmental, social, emotional, and cognitive triggers. And therefore, the diagnosis is most often based on history and physical examination. More stress cannot be spoken about the history and physical examination. We have a separate session on this later during the month. And therefore, because there are two movements of the temporomandibular joint, in the upper joint and the lower joint, it's called as a gynglymodiarthrial joint. Coming to the bony parts of the temporomandibular joint, we have the fossa and the condyle. Many times as oral surgeons and operating surgeons, we don't worry too much about the fossa. We are more focused on the condyle. We will discuss the anatomy of the fossa in the following slides. We have the cartilage, which is the meniscus or the articular disc, very important for all of us to note the function and the anatomy of the cartilage. There are soft tissue muscles, ligaments, and there is the space. Let us not forget about the space which contains the synovial fluid, which is the upper joint space and the lower joint space. So how does the temporomandibular joint develop? Well, one needs to know the embryology of any structure because a lot of defects can happen during the growth of the fetus. The joint develops from the first pharyngeal arch. There are three stages: the blastemic stage, the cavitation stage, and the maturation stage. The blastemic stage is the formation of the fossa, and the condylar blastema starts here. It is in the 7th and 8th week of gestation. In the cavitation stage, the lower joint space begins, and also the beginning of the disc. And this happens between the 9th and the 10th week of gestation. Here, the blastemas start to differentiate into layers, and they form the lower joint space. In the maturation stage, the upper joint space begins to form, and this happens during the 11th week of gestation. You have to understand that the joint will continue to form until the baby is born. And around 17 weeks, the joint capsule is formed, whereas at around 19 to 20 weeks, the development of the cartilage inside the capsule can be recognized. Why is this important is during this period of development, there are a lot of influences which can affect the development of the joint. For example, you can think about the golden hair syndrome and the stapedial artery. We won't go into the details of this. At birth, temporomandibular joint, when compared to other synovial joints, is not fully developed. This is also important for us as surgeons. The jaw will begin to develop from the 4th week, and the temporomandibular joints develop simultaneously with the ear. In the child, there is a more obtuse mandibular arch, whereas in the adult, the mandible tends to be more angular and sharp. In the child, the glenoid fossa is loose and the cartilage is not yet present, but there will be a filling of fibrous connective tissue. Between 5 and 10 years of age, the condyles grow in a posterior, lateral, and upward direction, please note that this affects the ramal flare of the mandible. The joint space will be further managed by the mechanical forces of the teeth and the chewing muscles. All this has been discussed in detail by the orthodontist Melvin Moss in his theories. We come to the glenoid fossa now. They are formed from the squamous and petrous parts of the temporal bone. It is oval in shape. It is bounded anteriorly by a projection called the articular tubercle. Please note that the shape of the articular tubercle dictates the movement of the joint anteriorly, and the slope of the articular tubercle tends to dictate on which movement of the condyle happens. Posteriorly, it is bounded by the tympanic part of the temporal bone, and there is a small posterior glenoid tubercle here, which prevents the posterior displacement of the joint. It is divided by the petrotympanic fissure. Why this is important is the cauda tympani nerve tends to emit from the petrotympanic fissure, and we need to make sure that we understand this also, not only the stylomastoid foramen where the main branch of the facial nerve exits. The anterior part articulates with the condyle, this is made of trabecular bone. Therefore, there are many more morphological changes that happen in the anterior part rather than in the posterior part. And the posterior most portion of the mandibular fossa is formed by the tympanic portion of the bone. This is non-articular, and sometimes it lodges a portion of the parotid gland, especially in the people with parotid hypertrophy. What determines the fossa anatomy? There are a lot of things that can determine the fossa anatomy, which is why there are so many variants of fossa anatomy as well as variants of the condyle. The functional loads, the amount of load that happens on the condyle also is on the lower jaw is also very, very important for the shape of the glenoid fossa. The disorders and abnormal mandibular morphology, the mandibular position, the occlusal force and masticatory muscle activity. Think of paranormal habits and the changes that happen in the glenoid fossa due to paranormal habits. The facial pattern, there are diculocephalic, brachiocephalic, and so on and so forth. This also determines the shape of the fossa with terms of depth of the fossa. The dental pattern, which includes missing teeth or multiple teeth or malocclusions. The condylar inclination and the rotation pattern of the condyle, and the growth pattern of the face, especially in vertical growers, the glenoid fossa tends to be very different from others. Coming to the area of interest for most oral surgeons, the mandibular condyle. We are all very intimately aware of the anatomy of the mandibular condyle. The condyle consists of two portions, the head and the neck. It is an articular surface which, along with the meniscus, forms the temporomandibular joint. It is convex in shape. Its long axis is directed medially and slightly backward. We spoke about ramal flare in the previous part of the lecture. This is the same thing. At the lateral extremity of the condyle is a small tubercle for the attachment of the temporomandibular joint ligament. The neck is flattened from before backward and strengthened by ridges on either side. The posterior surface is convex. This is the pterygoid fovea, and this presents a depression for the attachment of the external pterygoid or the lateral pterygoid muscle. What is the size of the mandibular condyle? Roughly, it is 15 to 20 millimeters side to side and 8 to 10 millimeters from the front to back. Again, like the glenoid fossa, there is a great variation in the size and shape of the components of the temporomandibular joint and the relationship of the meniscus and the joint to each other. It is often assumed that both condyles tend to be similar in shape. This is not necessarily true. There are many times when both condyles are very different from each other. A normal variation of the condyle morphology is dictated by age, gender, facial type. All the variations that happen with the glenoid fossa and the variables also happen in the condyle. And most of the time we see that the advanced morphological changes are detected in elderly persons due to the onset of joint degeneration. This figure here shows the linear measurements of the condyle with relation to age. And what are the shapes of the mandibular condyle? The shapes of the mandibular condyle, from when you look at it from laterally and from behind, are rounded, angle, flattened. And when you look at it from above, they are biconvex, biflattened, and mixed. The rounded condyle and fossa are the most frequently seen, and in the lateral and posterior views. From when you look at it from above below, the mixed shape and the biconvex shape of the fossa was most common. Rarely we see a bifid condyle. This is of more importance to the surgeon. What are the shapes that you can expect to see when you open the condyle? When you open the temporomandibular joint capsule and you see the condyle with the naked eye, you can see the normal rounded condyle. You can see an excavated form of the condyle with a lot of loss of bone medially. An oblique shape of the condyle. You can see a smaller rounded condyle or a flattened condyle. Flattened condyles are usually associated with pathologies. More importantly, what are the ligaments that affect the movement of the condyle? Most ligaments are there to limit the translation of the condyle. They are very, very important, and they work in conjunction with the muscles of mastication and accessory muscles of the TMJ. There are several ligaments that manage the TMJ forces. They also have a role of sending multiple proprioceptive afferents, and the proprioceptive afferents are sent from the capsule, the muscles, the skin receptors, and receptors within the periodontal ligaments. The tension perceived by the articular ligaments plays a very important role in the function of the temporomandibular joint. This, coming to one of the ligaments, the sphenomandibular ligament is a remnant of the Meckel's cartilage. It comes from the sphenoid spine and goes in and attaches to the lingula of the mandible. Along this path, it is inserted into the medial wall of the temporomandibular joint capsule. It also involves the malleus of the ear and contributes to some fibers of the anterior ligament of the malleus. Most importantly is it protects the temporomandibular joint from excessive translation of the condyle after 10 degrees of the opening of the mouth. The stylomandibular ligament is nothing but a thickening of the deep cervical fascia, in particular the parotid fascia. It comes from the styloid process to the posterior margin of the jaw. It serves to limit extrusive protrusion of the jaw. The pterygomandibular ligament is a thickening of the buccopharyngeal fascia, contributes to the buccinator and the superior constrictor muscles. It comes from the hamulus of the pterygoid plate to the retromolar trigone of the mandible, and this limits excessive jaw movements. The pinto or the distomaliar ligament, it has two portions. The first portion involves the malleus. The second portion involves a portion of the temporomandibular joint. And the functions of the distomaliar ligament are twofold. It protects the synovial membrane, and in the ear, it tends to manage or influence the pressure. The collateral, these are all small ligaments. The collateral ligament consists of two bundles that originate at the level of the intermediate fascia of the disc and insert at the median and lateral poles of the condyle. This serves a very important function. It serves to anchor the disc to the condyle. The joint is related to different muscles of mastication and suprahyoid muscles that move and protect the joint. We will not go into details of this because I'm sure everybody, especially the postgraduate trainees, are very, very intimately familiar with these things. The temporomandibular joint ligament or the capsular ligament, it connects the tubercle of the arch to the lateral and posterior border of the neck of the mandible. It prevents the posterior displacement of the mandible. And importantly, it prevents the condyle from being driven upward by a blow to the jaw, which would otherwise fracture the base of the skull. You need to know that the neck of the condyle is also narrow to prevent the condyle from being driven upward by a blow to the jaw, and therefore most fractures of the condyle tend to happen at the neck of the condyle. This is a protective mechanism of the body. I'd like to thank Dr. Muthuseka for contributing to this particular slide. He's the one who told me about Tanaka's ligament, and I went and read up about Terry. I read up Terry Tanaka's paper. It was quite interesting. This is a controversial ligament. Some people, especially Oke-san, still mention this ligament in his textbook. And Gray's in the older editions mentions Tanaka's ligament. In the newer editions, this has been omitted. So, but this is there, whether it is, whatever the name is, this is anatomically present. It is an intracapsular ligament of the temporomandibular joint that unites medially the articular disc and the mandibular fossa. This helps the disc to luxate medially in the case of impacts. So it pushes the disc medially in the case of impacts. So a synopsis of the ligaments of the joint is important now that we've finished the discussion of the anatomy. The extracapsular ligaments are the temporomandibular, sphenomandibular, and stylomandibular ligaments. And the intracapsular are the medial and lateral collateral ligaments. And the temporomandibular joint ligaments help to limit the movements of the joint. This is very important. They help to limit the movements of the joint. We also need to recognize the condyle as a center of growth. The mandibular condylar cartilage is the center of greatest growth in the craniofacial complex. All of us know that disturbance of the condylar cartilage tends to result in many pathophysiologies of the joint, including ankylosis. The condylar process grows in a wide range of directions, which has been discussed priorly. The growth direction is closely related to mandibular displacement. And the condylar cartilage, this is secondary cartilage, and it differs from other primary cartilage. And this cartilage, even though the condyle is a synovial joint, is completely different from other cartilages of other synovial joints. The cartilage contains fibroblasts, progenitor cells, and chondrocytes. There is type 1 collagen, and there is co-localization of type 1 and type 2 collagen, which may be an adaptation to the complex biomechanical environments of the condylar cartilage, which basically means that since both the condyles move at the same time, and each condyle has a role to play in the movement of the other condyle, there is a biomechanical evolution of the cartilage which is not available in other synovial joints. The peripheral condylar cartilage contains chondroid bone. This is a specialized calcified tissue which is between bone and cartilage, and this plays an important role in the rates of bone formation in intramembranous and endochondral ossification of the mandible. So coming to one of the more important aspects of the temporomandibular joint, the disc or the meniscus. It is a thin oval plate of non-vascular fibrous connective tissue. It is divided into two parts, an outer fibrous layer and an inner synovial membrane. The thickness varies from 2 millimeters anteriorly to 1 millimeter in the middle and 3 millimeters posteriorly. And it is located between the condyle and the mandibular fossa. The upper surface is concavo-convex and the lower surface is concave, classically called as peaked schoolboy's cap appearance. The circumference is connected to the articular capsule and in front to the lateral pterygoid muscle. It is thicker at its periphery and thinner at its center. And importantly, it divides the joint into two cavities, the upper joint cavity and the lower joint cavity. And the anterior portion attaches inferior to the condyle and superior to the eminence. It is attached posteriorly to the temporal bone, and laterally and medially it tends to blend into the joint capsule. And posteriorly, it also attaches to the bilaminar zone, which is a very important and vascular structure. The disc prevents the mandible from moving posteriorly. The articular disc of the joint contains three functional zones. There are the anterior, posterior bands, and the intermediate zone. The intermediate zone is the thinnest portion, as discussed priorly. It allows flexibility and smooth articulations and protects the articulating surface. The bands that are located in the periphery of the disc, they are thicker and they fill the space created by the condyle, and their function is to stabilize the disc and provide structural integrity. The purpose of the condyle is to allow the convex surfaces of the articular eminence and the mandibular condyle to remain congruent through the range of motion of the temporomandibular joint in all planes. It is possible that because of the thinness of the intermediate zone of the disc, most pathologies and tears of the disc are seen in this particular zone rather than in the anterior and posterior zone. The two bands of the bilaminar disc zone are attached to the disc. The superior band allows the disc to transit anteriorly, and the inferior band is attached to the condylar neck, and it is inelastic. It basically serves to prevent the forward translation of the disc, and this has an ability to remodel and repair the disc, that is, and thus it is able to tolerate repeated high-level stresses. Very important. Without the ability to remodel and repair, there would have been many more discs that were irreparable or needing repair surgically. What is the synovium? A very important part of the temporomandibular joint. The capsule is divided into two parts: an outer fibrous layer and an inner synovial membrane. The synovial membrane consists of the synovial lining layer and the connective sublining layer. The synovial membrane covers the inner surface of the articular capsule in the temporomandibular joint. It consists of two types of cells: macrophage like type A and fibroblast like type B cells. More importantly, the synovial fluid acts as a lubricant and a shock absorber. facilitating smooth jaw movements by reducing the friction and cushioning the articular cartilage and other tissues. Different stages of temporomandibular joint disorders can be attributed to the changes in the lubrication capacities of the synovial fluid. So if there are any, if there is a decreased amount of synovial fluid, then there are chances of temporomandibular joint disorders. So this also acts as a medium of osmosis between the joint and the blood supply and protects the cartilage against enzyme activity. This has been implicated in the progression of cartilage deterioration and osteoarthritis, and it's an ultrafiltrate of blood with additives produced by the synovium to provide nourishment for the avascular cartilage. So now there are a lot of research about whether the synovial fluid has hyaluronic acid or lubricant. These are interesting researches. There is no consensus as of now, and maybe in the future we'll have a consensus of what makes up the synovial fluid. So that's about the synovial fluid. Coming to the spaces, that is the joint cavity. The disc divides the cavity into two smaller cavities, the superior and the inferior. The superior compartment is larger than the inferior compartment. Both the cavities are lined by the synovial membrane and filled with synovial fluid. The upper joint compartment is responsible for translatory movements, while the lower joint compartment is a hinge joint providing rotational movements. Therefore, the name of the temporomandibular joint is the Gingline or diarthroidal joint. What is the vascularity? Many times we forget about the vascularity to any bone. It's very important to know the vascularity, especially from the applied anatomy aspect of the condyle. The branches of the superficial temporal artery, the deep auricular artery, the anterior tympanic artery, and the ascending pharyngeal artery all contribute to this particular region. The nerve supply is the auriculotemporal nerve, which is a branch of the trigeminal, the mesenteric nerve, and the deep temporal nerve, all branches of the fifth nerve. So that is the anatomy of the temporomandibular joint. Moving on to the biomechanics of a synovial joint. This is not the biomechanics of the temporomandibular joint. In general, we need to know the biomechanics of any synovial joint before going on to the discussion of the biomechanics of the temporomandibular joint. First of all, let us try to understand what means the term biomechanics. The study of the mechanical laws relating to the movement or structure of living organisms is called biomechanics. So synovial joints are the most common joints of the human skeleton, and they represent highly evolved movable joints. But even though they are movable, the degree of motion varies according to the individual structural design and the function. The bones form the lever arms, the cartilages transmit force and therefore reduce the friction on the bones. There are layers of cartilage. The outermost layer is known as the gliding zone. These are dense layers of collagen, which provide strength to the joint in normal motion and protect the deeper cartilage layers. The translational zone lies beneath the gliding zone. Here, the fibers change from parallel to perpendicular, and the articular cartilage is considered mostly avascular. It lacks a perichondrium and therefore must rely on all other sources for nutrition, removal of waste products, and for repair. The orientation of the fibers, which change from parallel to perpendicular, helps in the exchange of nutrients and the waste products. Coming to the biomechanics of the temporomandibular joint, it is a lever of third class, which basically means that the force is between the fulcrum and the load. They are very complex joints, and they are the only joints that work in congruation with the other side. They are a compound joint, and these joints allow the mandible to move up and down, side to side, and forward and back. What are the movements of the temporomandibular joint? There are mandibular movements, which are protrusion, retraction, elevation, and depression. And what about the two joint system? We have the upper joint cavity, where there is a sliding motion, which is more than 25 millimeters, which is called translation. And the lower joint cavity, which is the hinge motion, which is less than 25 millimeters. And this is the rotational movement of the temporomandibular joint. As we all know, the movements require tremendous power, and the TMJ is designed by God to accomplish this. There are both osteokinematic and arthrokinematic. Osteokinematic means motions of the bone, which include mandibular depression, elevation, protrusion, retrusion, and left and right lateral excursions. Arthrokinematic involve rolling, anterior glide, distraction, and lateral glide movements of the temporomandibular joint. So how does protrusion and retrusion happen? Protruders are the lateral and the medial pterygoid muscle. Retractors are the temporalis, digastric, and the geniohyoid muscles. The protrusion and retrusion happens in the upper joint space. It is an anterior-inferior movement and a posterior-inferior movement, which are dictated by the eminences and the tubercle of the temporomandibular joint. No rotation happens here. Okay, no rotation happens in the upper joint space. The teeth do not meet when these movements happen. And the temporomandibular ligament tension limits the retrusion and the bilaminar zone at the back. Again, having mentioned the bilaminar zone, you need to understand is a highly vascular zone, which contains of upper lamina and lower lamina. This also prevents the increased retrusion of the joint. And what about the lateral excursions, elevations, and the depressions? The depressors are the lateral pterygoid, the digastric, geniohyoid, and mylohyoid complex. And the lateral movers are the medial and the lateral pterygoid. And the muscles that elevate the mandible are the temporalis, masseter, and the medial pterygoid. To accomplish lateral excursion, it spins around the vertical axis within the mandibular fossa. And very, very important to note that to accomplish this lateral excursion, the contralateral condyle also should move anteriorly in the eminence. A slight degree of spin and lateral glide of the contralateral condyle is necessary to achieve maximum lateral excursion. So the joints need to work together in order to give maximum beneficial function. What are the changes and the movements of the disc? The shape changes on pressure. The anterior and posterior zone, they have increased with and decreased pressure. The intermediate zone has decreased with increased pressure. And the retrodiscal tissue retracts the disc. This is the bilaminar zone also. And the lateral pterygoid muscle advances the disc. And what are the other changes that happen in the temporomandibular joint? Mechanical loading is very essential for the growth, development, and maintenance of the tissues. Just because there is no function doesn't mean that the joint will grow. You need, for optimal joint function, you need to have some amount of load. If the temporomandibular joint had no function, they were not loaded, then the joint tissues would do this degenerative changes, which is disuse atrophy. If there is too much loading, which means under physiological conditions, if there is loading, then it is okay. But if there is too much loading, which will exceed the normal adaptive capacity, this can lead to degradation and deterioration of the temporomandibular structures. So what is the take-home message? Before we come to the applied anatomy, the take-home message of the biomechanics and the anatomy of the temporomandibular joint is, the function of the joint does not depend on ligaments being active. There is absolutely no stretching of the ligaments, and there must be constant contact between the fossa, meniscus, and condyle for optimal function. So let's just go to the chat and see if there are any questions with regard to this. Okay, we will come to your question. There is one question. We will come to the questions later. Going on to the surgical anatomy. So this is a photo taken by my friend, and this tusker nearly killed me. This was many years ago, and and this photo I always put up to tell us about the hidden dangers of operating on the temporomandibular joint. The most important structure that actually limits us to the surgery of the temporomandibular joint is the seventh nerve. It is the most important structure that needs to be preserved. And one must understand the relation of the facial nerve with the temporoparietal fascia is very important to the surgeon. Any procedure that happens beneath the temporoparietal fascia tends to preserve the nerve. And you need to limit yourself to dissecting up to the joint from beneath the temporoparietal fascia. There is a line. So the distance from the bony part of the external acoustic meatus to the joint is 1.5 to 2.8 centimeter. There are certain landmarks. The line that is connected from the tragus to the lateral palpebral commissure, that is the eye, is considered the superior limit of the temporal branch of the facial nerve. In my experience, the temporal branch of the facial nerve is the one that never comes back after palsy. Most other nerves tend to come back, and most importantly, the eye branch tends to come back. But the temporal branch many times doesn't come back. We will discuss this with the panelists later. In the subcondylar approach to the condyle, the most important branch is the marginal mandibular branch. You have to understand that as it comes up from the submandibular gland, it tends to pass the bony part of the mandible, and posterior to the posterior ramus is the marginal mandibular branch of the facial nerve. But again, in my opinion, the most important branch is the eye branch, and all efforts have to be taken to preserve this particular branch. There are some papers, I do not have experience about this, we will discuss with the panelists later. There are some papers that mention that the auricular temporal nerve also can be damaged as it passes behind the neck of the condyle. So I have no experience with this. We will discuss this later. What about the bleeders? For the more senior surgeons, hitting the nerve is a problem. For the younger surgeons, it is the bleeder that is the problem. So after 20, 25 years, I don't think any of us worry too much about the bleeders. But yes, I would really worry about damaging the facial nerve. So what are the bleeders that are there in this region? What are the things that can give you nightmares intraoperatively? The IMAX, that is the internal maxillary artery, the superficial temporal artery, and the retromandibular vein. The retromandibular vein is encountered only if you do a transparotid dissection. The superficial temporal artery tends to pop up all the time when you are doing the preauricular approach. It's not difficult to retract it, but if you are going to use temporoparietal fascia for something, it is better to retain this particular artery. And the temporoparietal fascia is a very important landmark, as mentioned before, because all the structures tend to be above the temporoparietal fascia. And between the temporoparietal fascia and the zygomatic arch is a very decent avascular zone, which can be used for a clean dissection of the joint. The internal maxillary artery was measured to be in contact with the medial cortical surface of the mandibular condyle in 39 of the 52 angiographies. Interesting, isn't it? It's all on the other side of the condyle. And the contact point was found to be 1.7 millimeters in front of the posterior margin of the ramus. So everything seems to be covered under the condyle, which makes it a blessing in disguise as well as an issue to get control if it starts bleeding. So what are the approaches to the temporomandibular joint? We have the preauricular approach, the submandibular, the retromandibular, the rhytidectomy, the transmesenteric anterior parotidectomy approach, the intraoral, postauricular, and the incision. Dr. Arun, who is our panelist here, has done a fantastic series of cases using the incision, and we will discuss this with him later on during the lecture. Why should you know the extent of access? To decide on doing a good surgery and to get good results, you need to know how much of the joint you need to expose. So we have the preauricular approach, the residence, the retromandibular, the rhytidectomy, and the transmesenteric anterior parotidectomy as well. My favorite approach is the rhytidectomy approach to most problems of the temporomandibular joint. This gives me adequate exposure, and if need be, I can connect the lower portion and the upper portion, keeping a bar of parotid tissue in between to encase the facial nerve. But we will discuss again with our panelists their favorite approaches and why they prefer this particular approach. The classical preauricular approach, when we were training, our teachers taught us this approach. The retromandibular approach has just come into fashion at that time. So most of the joints were opened with the preauricular approach. So you need to worry about the main trunk of the nerve here. If you can make it endoral, it make it cosmetically better. It can be used for most joint surgeries and for ankylosis. When it comes to fractures, it is very difficult to plate condylar neck fractures. It can be used for high condylar fractures. You need to have least manipulation of the facial nerve here. You can't afford to be very rough. And lower mandibular access is poor. But the advantage is you can approach the arch and the temporal fossa also. And in cases of ankylosis, you can approach the temporalis muscle also in the same incision. The retromandibular approach, very commonly used approach for fractures of the condyle. You need the landmarks are the earlobe and the parotid capsule. The branches at risk here from the facial nerve are the buccal branch and the marginal mandibular branch. Hind's incision is placed between the two branches of the nerve. And this can be used to treat most types of condylar fractures except the head of the condyle. Again, this is not an approach for anything except condyle fractures. Residence approach, or there is a modification of residence approach called the periangular approach. Both these are subcondylar approaches. The nerve at risk here is the marginal mandibular branch. Ideally, you place it in the lower skin crease. The traditional thing of 2 centimeters below the angle of the mandible doesn't hold good anymore, because sometimes the scar can be difficult to hide. And in case you encounter the marginal mandibular branch, you can use the Hayes-Martin technique if you use a low skin incision, which basically means you can tie off the posterior vein and lift it up and go beneath the vein to prevent damage to the marginal mandibular branch of the facial nerve. It is an excellent technique to reach the lower part of the condyle. And the rhytidectomy approach, this is the classical rhytidectomy approach. In recent times, you can limit the anterior incision to the attachment of the ear, and posteriorly you can go up to the mastoid process. So this gives fantastic exposure to the joint. It can be used for anything, including ankylosis or disc repair or anything. Again, the main branch of the nerve that is at risk here is the main trunk of the nerve. You need to identify the parotid capsule, but in my exposure, in my experience, the biggest problem of rhytidectomy approach tends to be close parotid fistulas. We will come to that later. And ideally, if you use your bipolar again and again and again, the amount of damage to the facial nerve is extremely limited. So this can be combined with the bicoronal approach also, in case there are other fractures, to give a cosmetically pleasing result to the patient. So we did 2 cases like this, and both cases we couldn't find the condylar segment, and we needed to skeletonize the nerve because we were not too sure where the nerve was. And in both the cases, we had transient facial palsy. We were lucky it was not permanent, but you can notice the difference. In the left-hand side, if you can see my pointer, this is the nerve that is completely skeletonized. And in the right-hand side, we kept a bar of normal salivary gland tissue, but it didn't seem to make any difference. In both cases, the patient had transient palsy, which recovered within 6 months. So you need to know about this as the TMAP approach. The classical alkyd Bramley, it's a very, very interesting paper, and this comes in the exams all the time. Question mark shaped incision. So when, as a matter of note, before I went bald, I like this incision. So after I went bald, I prefer not to use this incision because the anterior portion of the incision tends to, you can't really hide it too much. So this is also a good incision, and it is a modification of the preauricular incision, mainly used for ankylosis. Very important to do the facial nerve assessment before and after. There is no point in doing it just after and telling the patient that, the facial nerve has been affected. Medical legally, it is important for you to take consent for facial nerve palsy also. And we will come to this slide later. That comes to the end of my lecture. So Dr. Jimson, should we start with the question and answer session for the panelists? Or?
Yeah, please go ahead. Kannan?
Yeah, thank you, Dr. Satish, for this elaborative lecture, and he's covered almost all aspects. I think I see some people have typed in their questions here and in the chat. As participants, please keep typing in your questions. In the meantime, to keep up, we will have an interactive panel discussion. The panelists and the speaker themselves have a list of topics wherein they want to discuss. So as they are discussing, we would encourage others to start. Dr. Satish, shall we just take off this one question for
yes, Doctor.
The first one, which came much above by Dr. Malar. Does condylar growth center also contribute to the transverse growth of the face? Then you can go, once we address this, then you can go on to your questions, and then we'll come back to the rest, which are just coming in now.
Thank you, Dr. Kannan. So our panelists are here. So Dr. Chitra, would you like to take this question? Does condylar growth center also contribute to the transverse growth at the midface?
I'm not aware of any study that actually says that, but because more or less the growth centers are working in sort of unison with each other, as the cranial growth center keeps growing horizontally as well as, vertically as well as transversely, I think the mandibular growth center also contributes to some extent to the transverse growth of the face. But I'm not very sure about this because I have not really come across any article which says that.
Thank you, Dr. Chitra. So going on to our questions here, I've tried to put it in order of importance according to me.
1 second,
So-
Satish, we will
Yes.
just clarify and elaborate there. Just
Okay.
to Dr. Malar, the condylar growth center primarily only contributes to the mandibular growth. It's not part of the midfacial growth. Whereas, will it contribute to it in a case like ankylosis where mandible can't grow and the rest of the structures can't grow with it? Maybe it will indirectly influence. That's what Dr. Chitra was trying to say. There is no recorded study also to say. And embryologically, condyle is only supposed to help with the growth of the mandible. It's got no direct role onto the midface at all. Okay, so
Thank you,
please
Dr.
carry on.
Kanan. Thank you, Dr. Kanan. The first question will be to Dr. Muthuseka and Dr. Arun. Muthuseka sir, if you would like to take the question. How will you avoid the facial nerve during temporomandibular surgery? And do you have any experience with the use of nerve testers?
I have not used a nerve tester, but as you yourself tend to get that clear zone. You just go below the parietal fascia. If you identify that and go in that space, 90% of the facial nerve will not get damaged. If you take that so precaution, that is good. But I for TMJ surgeries, I don't use nerve sensor or anything to find out whether the nerve is coming there or not. But
Thank you,
just
sir.
take that plane exactly in the parietal fascia where you get the clear zone, avascular zone, and go in that plane. 90% of the cases you don't involve the nerve at all. You are very safe.
Thank you, sir. Dr. Arun, what about your experience? Do you think that the nerve damage is permanent? I think 98% of the times it's transient and it all tends to come back.
Mostly if you adhere to the surgical principles and the layers.
Dr. Arun, we can't hear you too well.
Am I audible now?
Yes, much better. Thank you.
Yeah. A thorough anatomical knowledge and the surgical technique avoids permanent damage to the nerve. As you say, for a pre-auricular approach, Alkayat Bromley is our favorite approach. Once you're down to the layer, you make an incision at a different layer down to the nerve. So the flap contains the nerve. Also, if you go beneath the temporoparietal fascia, your temporal branch is completely avoided. Maybe due to some heavy retraction, you may have some temporary paresthesia. Otherwise, you don't have injured the temporal nerve at all. And for submandibular residence incision, again, if you there are few branches, right? That is the issue. Now there is not a single branch as a mandibular marginal mandibular branch. Sometimes it may have 2, 3, or even 4 branches. That is the issue where you get some paresthesia post-operatively. So you have to adhere again deep to the latticema. That is where your nerve lies always. So be careful while operating, and facial artery is the region where you have to identify the nerve. Try to identify the nerve, see the nerve, retract properly, and ask your assistant to be more careful while retracting. So that way you can prevent these nerve injuries.
Thank you, Dr.
Adherence to
Arun.
the principle of layers. Yeah.
Thank you, Dr. Arun. As a matter of interest, many years ago when I was in Jaipur, Dr. D.K. Gupta showed me a technique of his, and he went right to the temporal bone. He didn't bother about dissecting under temporoparietal fascia, and this was for ankylosis. So he went right to the temporal bone and dissected down into the mass, and he had a large series of cases with zero facial nerve palsy. So if any of the younger residents are interested, the papers being quoted in the presentation, you can read it up. Dr. Jimson would like to answer Dr. Muller's question. Does condylar growth center also contribute to transverse growth at the midface? Dr. Jimson, would you like to take that question now? No? Shall we?
Satish,
Yes.
Dr. Satish, just 1 second. There is a question relating to the nerve stimulator as well. How accurate from Dr. Keshav
Yes.
Pawar. So we are in that, one of the questions which has come.
So in my experience, I keep the nerve stimulator, but many times we don't find the skeletonization of the nerve happening when we dissect into the temporomandibular joint. But I keep it on standby. What I do, and it helps me, is I tend to ask my anesthetist to use Atra and then keep the patient on propofol, and the twitching of the facial nerve is very evident when you come closer to the nerve. I mean, the other panelists are always welcome to give their ideas. Please, can you contribute to this question? which I
Can
think is an
I chip
Kannan.
in, Dr. Satish, just with your permission? No,
Yeah,
as
please.
you rightly said, most of the techniques you can avoid the nerve except transparotid where you're through the nerve. So
Right.
there, and as Dr. Satish said, they are accurate, but more often than not, you have to avoid, not always you have to avoid muscle relaxants, but it is difficult inducing. So they will use atracurine, which Dr. Satish was referring to. And because it's short acting, by the time you start, the effect of it would have been worn away. And if you're
Right.
dissecting and you're dissecting close to the nerve, there will be some twitching across. So your draping should show the corner of the mouth, then you can find it. If you're still doubtful, you can use a a stimulator. But remember, a stimulator will stimulate everything. And if the nerve is in the proximity, it will still stimulate.
Yes, and it's also important to ground the stimulator. If you don't ground your stimulator
Grounded.
properly.
No, now
then,
there are
you
now
know,
new peripheral ones which you don't need to. You just touch that
you
and
don't-
then
yeah,
it
you
will
need to
act.
touch the nerve and
So
it lights up. Yes.
it lights. So
Yes.
sometimes what we can do is take down the reading on the stimulator right to the lowest touch and see. So if it's directly on the nerve, whatever is the reading, it'll even the lowest will stimulate the muscle. Whereas when it's high, everything starts contracting.
I think the most important thing is what Dr. Muthusekar and Dr. Arun said. You need to know your anatomy properly and try to stay away from the nerve.
No,
Yeah,
but
most
So
of
that's
the
the
time
best
it will go into the
thing.
flap.
if you're using transparotid to reach, you will see the nerve and you want to retract it away. So it depends on the type of approach you're using.
Yes, yes.
Yeah,
And depends on your
exactly.
comfort level also.
Kannan.
Nerve
So,
stimulator. Can I comment? Nerve stimulator works when you identify the nerve. Most of the time it goes within the flap, as Kannan said, except for
I
transparotid.
agree with you. If you don't see
Yeah.
the nerve, then it becomes difficult to use the nerve stimulator.
Yeah,
I use
Another
it
thing-
most times when I'm in doubt. If I see something and I feel that it's the nerve, then I use the nerve stimulator to confirm. Otherwise, I
most-
do not.
Very true.
When
Kannan,
you
can I
use a
comment?
diathermy itself, sometimes you use a little diathermy there, you can see the twitching. So you be
Absolutely.
extra careful. So you know that you're very close to the nerve. So try to avoid in that way. So instead of depending on a nerve stimulator and having a nerve stimulator, the diathermy itself, you are very careful. And if you are using it very promptly, you can avoid this nerve damage.
Yes. I was chatting with a gentleman from Germany. He was a oral surgeon, singly qualified oral surgeon of the old school. And he mentioned that if you do not use electrocautery and you use only knife and scissor dissection, then the chances of the nerve getting damaged are lesser. I have no experience on that, but do any of the panelists have any experience of this?
Kannan, can I come in?
Please, Abhay, I was waiting for Satish to finish. Please come in. Yeah.
Yeah, Satish, if you don't mind, can I have a few words?
Please, sir.
Yeah. No, regarding the nerve stimulation, number one, essentially when you use it for your TM joint surgeries, we use this nerve stimulator for identification or a twitch, as Kannan said, the ones which are recently available from Mectron don't need a grounding, and that is mainly for the marginal mandibular. And as Dr. Muthusekar spoke about, essential anatomy of knowledge. And secondly, we have all spoken about preauricular approach as well as endoral rightidectomy. But if you look back into the paper by Deepika, I hope she's there in the crowd. She's written a fantastic paper. I think Deepika is from HOSMAT those days. She's written a nice paper on deep subfacial approach to the temporal area, which is a classic paper which helps in protecting the branches of the facial nerve. The only difference from the conventional approach to this approach is you are going one more layer deeper so that the nerve can get encased totally. And thirdly, there are two schools of thought, one emanating from the concept by Edward Ellis and the second concept which comes from George Dimitroulis, where Ellis speaks about the maneuver where he places a 45-degree incision staying close on the temporalis fascia with the periosteal elevator inside and scraping so that the nerve gets encased anteriorly. Whereas the other approach by George Dimitroulis, where he places a 45-degree incision staying within the confines from the root of the zygomatic arch 1 centimeter closest. Because you know from Peter Quinn's article, which clearly makes and speaks about using landmarks of 0.8 to 3.5 as the branching of the facial nerve. So you stay within that confines of the 1 centimeter from the root of the arch, and then put a releasing incision or an oblique incision following the contour of the tragal cartilage and you raise the flap, which is a reverse L fashion, automatically your nerve goes in the anterior segment. What I'm trying to convey here is there are different techniques of presenting or preventing a temporal branch or a facial nerve injury. It all depends upon the use of nerve stimulator is good, but however, these small techniques by Edward Ellis, by Peter Quinn, by George Dimitroulis do make a difference rather than the conventional. I'm sure Kannan and everybody would agree. We, from the old school, Dr. Muthushekar also would agree. We were all taught with the 45-degree release incision. Kannan, your thoughts on this?
Yeah, no, I agree. The idea of release, as he directly said, is just to answer Satish's point also. He using a scissors and just a force without bipolar. See, basically, most of the injuries in the approaches which you're saying is, and when you say the forehead, which is the last to recover, is usually traction injuries. And that is where the angulation and the angulation, that's where the angulation also helps and to spread it out and helps with the ease of retraction. Remember, the retraction injury is not due to the surgeon, it's usually the eager assistant on the opposite side coming forward. And one thing which we find is, which is the same as the lingual nerve, you know, our Langenbach edge, a sharp edge which you get from a local company, which is nice, broad or something, and you lean on it, the more it crushes the tissue under surface, the more the damage is. If it's a nicely spread, even one and nice, comfortable traction, shouldn't, and it should recover. So no, I agree. Abhay, maybe if you can put the citation here in the chat box or something, or in the question answers, so people will say Dr. Deepika citation, or Dr. Deepika herself can put the citation of her article, which Abhay was mentioning. So
absolutely, I'll try and put it up. Kannan, okay.
Thank you, Dr. Abhay and Dr. Kannan. The next question is for Dr. Jagdish. Dr. Jagdish, would you prefer the transparotid or the anterior parotid approach?
No, it depends actually on the size of the parotid to get access. If the parotid gland is small in size, then anterior parotid or retroparotid incision will help. But if the parotid gland is sufficiently large in size, then the access becomes a problem.
So this is a general
that
question
is when
for
we
all.
have to think of.
Sorry,
Yeah.
Dr. Thank you, Dr. Jagdish.
Yeah.
So this is a general question for all panelists here. Does anyone routinely avoid the parotid gland, or do most of you all go through the parotid gland by taking anatomical?
Satish, I used mostly retroparotid or transparotid rather than anteroparotid.
So you lift the parotid gland.
Yeah. So
you lift the isthmus of the gland.
Yes, that is retroparotid, not anteroparotid, because anteroparotid needs a more larger incision.
Correct.
And
you'll have to go up to the masseter and pull it out.
Yeah.
Yeah, I also prefer using the retroparotid actually.
Yes.
Because even the approach is much larger. At the same time, it also depends on, I think, which part of the condyle you're trying to approach. Depending on that also.
This would be in relation to the infrazygomatic incisions. But what about other incisions?
Satish, Dr. Satish, just to clarify, I think the first panelist, Dr. Jagdish, was talking about the approach for the parotid gland per se, and now we are talking about the bony approach, Dr. Arun and Dr. Chitra. Just to clarify, so the audience.
Yes. So there is a role for the audience. There is a role for both transparotid and retroparotid, anteroparotid approach. It depends on your choice and the anatomical variations that are there for that particular patient. So moving on to the next question. This is a question for Dr. Chitra. Dr. Chitra, how would you manage salivary fistulas? And would you avoid this through any techniques that you can use? Because if you go transparotid and the capsule of the gland is not sutured properly, you tend to have salivary fistulas, even though most times your nerve is safe.
That's right. The transparotid approach actually is a really good approach because it is closest to the ramus of the mandible. And in those cases, you need to sometimes go right through the parotid capsule and through the parotid to reach the ramus or the condyle in most cases. Of course, the most important thing would be to suture back the parotid capsule to make sure you get a watertight closure so you don't have a leakage of saliva later on. But in case you do have a salivary fistula, which you'll probably notice by the next day in the patient with a swelling in that region, you would probably first start with anticholinergic drugs. Some people, there are some articles which actually say that you start off with anticholinergic drugs even before you do the surgery itself or before you place the incision. But we would generally give it if you notice the salivary fistula. Pressure dressings definitely help, and I think repeated aspiration of the salivary collection from that area also would be helpful. A good pressure dressing in that area also would probably help.
Thank you, Dr. Chitra.
Anybody else? Yeah.
Does anyone have any experience with Botox? We've treated some fistula cases with 100 units of Botox and 4 ml of saline, and we use about 40-50 units of this, and tends to work well. But there is a risk of palsy because of the Botox, but it tends to be transient. But we've used it in cases which didn't settle down on conservative methods like Dr. Chitra so beautifully elucidated.
Satish.
Yes, Dr. Jagdish.
One second, Dr. Arun, Dr. Satish, just a housekeeping announcement. There is a feedback form put on by Dr. Jimson for all delegates. It'll stay open for 10 minutes till after the till the end of the session, or just about till the end of the session. Please fill it in and send it to get your certificates. If there is no feedback, there is no certificate.
Thank you, Dr. Kanan. A quick note from me. We have roughly about 20 minutes left. So can we rush through the questions? I think we've had some interesting discussions, and I would request my panelists if you could rush through.
Satish, just a small note. I think your idea of Botox is excellent, which is getting traction now. To avoid palsy, what we do is we do an ultrasound guided injection. You'll know where approximately the trunk is there. You get your anesthetic colleagues. It makes it even more safer, and you can spread it over different areas, multiple areas.
In fact, we use the Doppler that the anesthetists use for lungs.
Same
you
thing.
can use that, and it works really well because you can actually, the nerve gets highlighted in black, and you can
avoid that area or
in between.
Protect.
But whatever said and done, sometimes the nerve tends to get palsied, but this is temporary, and 3 months everything tends to come back. So
you can use antihistamines as well to reduce.
Yes. You can use monoamines oxidase inhibitors like amitriptyline also. But like I said, conservative is first very important. All the methods have been discussed by Dr. Chitra. So coming to Dr. Muthusekar now. So what would you say is the role of parafunctional habits in defining the anatomy of the temporomandibular joint, in your opinion?
Can you just repeat the question, Satish?
Yes, sir. So what would be the role of parafunctional habits? Sir, can you hear me? Am I audible, sir?
No, I can hear you. Yeah.
Yes, sir. So what is the role of parafunctional habits in defining the anatomy of the TMJ? Because I think among us all, you've done the maximum number of cases of open joint. And what is, in your experience, has been the shape of the fossa, the disc, and the condyle in patients that you operated for who have had parafunctional habits?
See, only for parafunctional habits, so opening the joint was not much. Only unless they have some disc problems and they have some reduced mouth opening.
Sorry, sir. My question was, when they had these problems and you opened the joint, did you see any changes of the bone or the meniscus which you could relate to the parafunctional habits?
I have not observed anything like that.
So anybody else in the panel? Yes. Thank you, sir. Anybody else in the panel? That? Yes, please, Dr. Chitra.
Yeah. So actually, there are a lot of studies also on this. I mean, there are studies on, right from I think 1980s, there have been so many studies regarding this actually, in which they have seen because of abnormal loading, cartilaginous degeneration takes place. There's also a more recent study actually by Huang et al. In 2023. Actually, there's a study in which they have picked up sleep bruxers by polysomnograph actually. And they have done an MRI and CBCT in these to see the soft tissue as well as the hard tissue changes in these type of patients. And they have seen a lot of disc deformity. They've even seen joint effusion as well as bony changes in the CBCT as well. I think the disc changes is basically because the type of changes that you would generally see would be more of calcification, the type of matrix, the collagen matrix that is there in the fibrocartilage of the disc, especially the intermediate zone is affected the most. There is a lot of calcification, fibrosclerosis, and also a lot of myxoid degeneration is apparently seen. with histological studies in these type of cases.
Thank you,
That
Dr.
is what
Chitra.
that article has spoken about actually.
So, continuing with this topic, I'm going to ask Dr. Chitra again. Do you feel that these changes are reversible?
I think in the initial stages, there are a lot of studies nowadays on the use of PRP in these type of cases where it's in, let's say, the initial stages of, not when it is in arthritic stage actually, or in the initial stages of class 1, 2, or 3, where you talk about, just changes in relation to pain and limited mouth opening. Where there is, we do MRIs where we see there's an anterior repositioning of the disc. The use of arthrosynthesis along with PRP is shown to have some amount of course, decrease in symptoms, definitely in the form of mouth opening, increase in mouth opening as well as relief from pain. But whether the disc really comes back to its original position and there is a regeneration of the disc, I think there are not many histological studies on that to actually support that.
Thank you, Dr.
Although
Chitra.
symptomatically there is a lot of relief in these patients.
Thank you.
Can I wait in just to
Yes,
throw
Dr.
on confusion or light? I don't think as of now medically we can expect any regeneration in the disc because it's cartilage and it's avascular. It's not going to even repair itself until otherwise we do. And that is what is the case with not only ours, entire orthopedic spectrum runs on it. So the discs are avascular. Reason they are avascular is they can act as pressure support. So wherever there is pressure, there is ischemia and pain. Because they are avascular, loading during function, they can withstand the loading better. And they protect the underlying lining as well. But once they start fraying and getting damaged, they lose the ability to repair themselves and they try and only adapt. So the induced changes with that, yes, and then very late on the surface of the bone, as Dr. Chitra also was saying, you get the indentations, but then it is difficult to say. Once the cartilage is breached, pain hits. Once it's beyond the pain layer, it's only the surface which is always painful. The adaptation happens, and then even if the bone is damaged, our pain might reduce. But if the pain is persistent, then it's a problem. So recapturing the disc by our own methods, functional methods, is very difficult to prove whether it happens, but pain settles down. What sometimes helps is even Botox, even if you give, it doesn't happen by itself. Physically, which I think Dr. Mutshekar has done, and you guys at Savita have done, and even others have done a lot of work on repositioning the disc mechanically. So anything with regard to morphological alteration of the disc, as of now, the proven way is only to do it surgically.
Thank you, Dr. Kannan. The next question is for Dr. Jagdish and Dr. Abhay. Can the lateral movements of the temporomandibular joint be replicated in a TJR?
Abhay won't finish this answer. Satish, be ready to come back into.
So we limit it to 2 minutes.
No, according to me, the natural movements will be little difficult with the total joint reconstruction, because the natural phenomenon, that is adaptation, is a problem with these alloplastic materials. So Abhay can.
I think last connection with Abhay.
Okay. So we will come back to this later once Dr. Abhay is here. So Dr. Arun, you must have seen a lot of ankylosis patients and released ankylosis patients in MDC. What do you feel is the role of accessory muscles for function after you take away the temporomandibular joint?
Actually, accessory muscles are really painful. Even though you get a good release, even though you get a good gap, the mouth opening is going to be quite difficult. I've seen so many cases after releasing so much of bone, doing a bilateral coronodectomy, still mouth opening was very, very difficult to achieve, particularly in long-standing ankylosis. All your muscles gets atrophied or fibrosed most of the time. It's not alone the accessory muscles, every muscle which is involved. Particularly, I see this temporalis, and it's actually a pocket of muscles. The whole soft tissue gets a cover, pterygium acid tristling, everything. It refuses to budge. So you need a lot of effort from the patient post-operatively and a lot of physiotherapy. I use ultrasound and infrared rays also to increase the muscle activity to improve the mouth opening later on to the ankylosis. We have seen so many cases with recurrence because of this muscle activity, despite creating a huge gap of removal of ankylotic mass.
Thank you, Dr. Arun. Mutseka sir, this is a question for you. Can you
Yes.
explain to us why condylar sag happens?
Condylar sag after TMJ surgery?
Yes, sir. Sometimes
No,
it's
after-
not only sagittal split osteotomy. Sometimes after
Yeah.
condyle fracture also people say that, I have not seen any research articles, but couple of case reports are there where they say the position of the condyle in the vertical dimension was reduced compared to what was there before. Ramal height complex. They talk about the Ramal condyle complex. So do you have any idea of this?
No, condylar sag I have not come across after TMJ surgery, like repositioning the disc or trying to do a high condylar shave. But after BSSO, yes, we few cases I have got the condylar sag. That because you are not positioning the condyle in the proper position, or your fixation is getting altered. So that's why I think, I don't know whether you have observed, whenever I do a base, so I tell my anesthetist to allow the patient to come out of the
Normotensive
relaxant, so that they'll start clenching the jaw. So at
Yes.
that time, I fix the jaw so that the condyle will go into its anatomical position because of the muscles. So and then mostly, if I do like that, it doesn't. I don't get a condylar sag. But
Thank you, sir. Fantastic tip for the postgraduate trainees. If you're doing a SAG and you want to avoid the condylar sag, then you ask the anesthetist to take the patient out of relaxant and then plate the condyle with the clenching of the teeth. Thank you, Mr. sir. So the next question is to Dr. Jagdish. Sir, in your opinion, which muscle has the maximum role in displacement of condylar neck fractures?
So if it is a high condylar fracture or this thing, it is a lateral pterygoid which plays a major role. But as we come down, then the temporalis and pterygomesenteric sling along with lateral pterygoid also play an important role in the displacement of these fractures.
Thank you, sir. So any other panelists would like to take that question? Which muscle do you feel?
No, once again, it's not about that question, Dr. Satish. There was a question, they can't find the feedback form. Feedback form will come towards the end of the session. Okay, sorry, continue.
So moving on to the, well, quite an interesting question for all of us here. So I'm going to ask all my panelists to get involved in this question. So in your opinion, what is the best way to control IMAX that's bleeding? Different people have different ways. I will then discuss my method also. So let's start with Dr. Chitra. Madam, what is your? I'm sure all of us have had IMAX problems, isn't it? When you're doing temporomandibular joint, all of us have had bleeders, and all of us have had issues. So, what would be your preferred way of controlling an IMAX bleed?
I think first thing is to try to avoid it. That would be the best thing.
And how would you do that,
if it is
madam?
possible? No, of course, not possible in all times, but knowing the anatomy, that the branch actually comes very close to the neck of the condyle and the medial surface of the ramus of the mandible, in very, very close proximity, actually. So probably dissecting in a layer where you're able to keep a retractor into that posterior surface so that the artery is pushed into that flap and it doesn't come into your zone. So I
you want to strip the periosteum off the medial surface of the condyle or the mandible,
not completely,
and push everything medially.
Yes, I would like to push it medially, especially use a malleable retractor in that area so that it is well protected and easy to hold also.
And if it cuts, I am being the devil's advocate here. My apologies. So suppose it cuts, then what do you do?
We start praying first, of course. Then yes, we try to control it as far as possible. With maybe, I mean, you try to clamp if it is possible. Of course, the bleed will be so high. Probably external carotid artery ligation would be your next approach to try and control the bleed in that area.
Dr. Jagdish, what about you?
Yeah. What I normally do is to apply pressure, control the bleeding, and then try and locate the bleeder.
So you would pack that area.
Yeah,
so
pack that
with
area.
What? With just gauze or with tincture?
No, with the
no,
with the gauze. With the gauze.
With just gauze. Okay.
Yeah.
Arun?
Yeah, that is a nightmare usually for any TMJ surgeon. Every TMJ surgery, we pray not to breach the internal maxillary artery. The first instrument I put is beneath the neck for all ankylosis is that obtrusive condylar neck retractor, right? Without that retractor, we never used to do any malleable is going to be difficult. You go subperiosteally. That is the best way. Identify the posterior border of the neck. Introduce your retractor right below your osteotomy. Whether you mostly I avoid using burrs, particularly on the medial aspect. I'm still in the
So
old school. Mostly I
you use
use
an
the burr.
osteotome.
Yeah, use an osteotome
Use
for
an
the
osteotome.
medial part because that prevents injury, and you have the retractor right behind your neck so that you prevent your injury. Always have the first cut down, right? So always do the first cut on the lower part so that the mandible is intact, and then the ramus moves off. If you're doing the first cut on the upper side, then your mandible is going to be moving, so you won't be able to do the lower cut. So always prefer the lower cut first for creating the gap, and then the ankylotic mass, which is near the condylar head, you can use it. And
Mutseka
always
sir, sorry,
condylar.
please continue, Arun. My apologies.
Yeah.
Sorry, I'm stuck for time here, so I'm rushing things. My apologies to
Fine.
panelists.
Fine. No,
Mutseka sir, how would you control the bleed?
Yeah. Mostly like what Arun was telling. I first use a condylar retractors, but on the side I keep the condylar retractor, and then I make the cut. Final cut will be with an osteotome. I'd never use a burr for the final cut. You come up to 75% of the cut you make with the burr, then the final cut use an osteotome, and you yourself use the mallet. Don't allow your assistant to use the mallet. You know that how much of force you have to use. Slowly you will get the tactile sensation, and then when you know it's fractured, stop with that. Don't try to go beyond that. You ask your assistant, you would have fractured it, but the third cut will come on the last cut. After you fracture also, it can then osteotome might go and damage the artery inside. So this cut alone, we use the mallet yourself. Don't allow the assistant to use it.
Thank you, Mutseka sir.
Can we think of Satish?
Yeah.
Can we think of using a Smith spreader and separating?
Yeah, that's what I do. I use a Smith spreader and I use a lot of bipolar.
Yes.
Or ligas. So I sometimes feel that magnification is very useful for me. So sometimes if I have an IMAX bleeder, I work with loops or using a scope. It's very easy to liga the branches or to bipolar the branches. It's not a very big artery. I remember Dr. Abhay, I'm pretty sure he's forgotten. He mentioned one time long ago that he packs this area with Whitehead's varnish. Is Dr. Abhay here?
Liga clips works wonder if you have one.
Other thing is, Ligas work really well.
Yeah,
Satish.
Yes. Yes.
Yeah,
Sir.
if the bleeding is uncontrollable, especially when you're doing a total joint replacement and there is an aberrant anatomy with regards to the maxillary artery, other than the Whitehead's varnish, what I have realized over these years is each time you're treating a case which is reoperated for ankylosis or a re-surgery where there is total discrepancy in the anatomy, and if you find a bleeder with your surgical loops, and if the bleeder is quite deep, remember when you have bleeders, and if the vessel gets lacerated during the surgical procedure, it's like a lizard's tail, which will get retracted and get pulled inwards. And that's the time you find these extreme difficulties. So off late, what I've done is, for deep vessels, I use the laparoscopic LIGA applicator, which is like a bazooka.
Yes. Correct.
This laparoscopic LIGA applicator is so easy to handle that you need to see it and visualize it under loops, under a 3.5, and go and hold on to them, and they do real wonders. Even the regular LIGA clips are good, but the ones which are deeper enough can be circumvented with your laparoscopic LIGA applicator.
I think the most important thing here is to have an assistant who knows what they are doing.
I have an assistant who understands our anatomy, our thinking concept, and the anatomy.
Correct.
So Satish Abhay, just one quick word. I think a question also has come up with the modern day. I think somebody, Dr. Anish Puna also has mentioned the question, using piezo might help your damage.
Absolutely.
These are all things which prevents actually.
Definitely. Can I just add in one more thing actually? Use of 3D printed models also will give you an estimation of how much of depth you really need to go. At least some estimation, at least for a newcomer, he will at least have an idea how much of bone is really there in that ankylotic mass to be going through.
Yeah, nothing like preventing, but once it happens, what you're supposed to do. I have heard so
Yes.
much often, despite doing this. The thing is, you have to pack by whatever means. Surgicel works. If it is a lower center, try for Surgicel. Pack. You can leave the pack for 24 hours. Take it later also. Another thing I come across recently is your Tissel, right? That is a fibrin sealant which works very good, right? You have to prepare that Tissel. It's quite expensive, but if you have a
How is
Tissel,
that spelled,
this
Arup? How is that
Tissel,
spelled?
Tissel. It comes from Baxter. It's a fibrin
Okay.
sealant. They use mostly in neurosurgical units. All you have to do is it comes as a two mix. You have to pack it as a syringe. You have to mix these two and then put it just over the pack and then leave it. It sets and it works wonders.
Thank you.
You pack it over that.
So postgraduates and people who are listening to this lecture, I think we've covered all areas. And there is one more thing which I have no experience of, and I do not know if my panelists have experience of, is embolization of the IMAX prior to the procedure. I've never done it. And have any of you all any experience with that? I've just read papers on this, and I've never done an elective embolization of the IMAX.
We've not done electively before, but post-op in trauma, 2-3 scenarios we have had uncontrolled bleeding after a week or 10 days, which we thought secondary. And we have done DSA, and then it is possible to embolize.
It is possible.
But just adding on to the previous, just a quick summary as said, or just a point, whenever the vessel is partly damaged, meaning partial tear, it will continue to bleed till it is addressed. If it's wholly transected, because arteries have muscles, they will tend to retract and collapse, and then your pressure, everything will definitely help. Whereas if it's partially lacerated and the other side lumen is wall is intact, it will stay open and it will bleed till something else is done. So if it's persistently bleeding in spite of packing for long, then consider that you only done partial damage, and that's a problem.
Yeah. So thank you, Dr. Kant.
Satish, as you're there is a question which says, can you throw light again on vascular anatomy, sorry, the blood supply of the
that is going to be the next topic of discussion with the panelists. One more question before that. So let me ask Dr. Jagdish. So what do you feel is the role of Melvin-Moss's theory in close reduction of condyle fracture? The muscle envelope, does it help in?
Satish, yeah, okay. We'll stick to it because there's another entire lecture on condyle fracture. So we will look at the.
So this was more with the relation to Moss's theory.
Yes.
So,
yes.
But the muscle envelope. So.
Yeah. So basically, it is the functional adaptation, neuromuscular adaptation. That is the one which will take care of the condyle and the function in a close reduction of the condyle.
Thank you, Dr. Jagdish. Yeah. Last question for the panel before we take the questions from the students. How many of you all ligate the retromandibular vein when you're doing the transparotid, or will you retract? Anybody would like to take the question? I'm not sure who to address it to because all of you all do life surgeries.
Through transparotid, is it?
When you're doing a transparotid, when you're going through the parotid, sometimes you get the retromandibular vein.
Yeah.
Would you retract it or ligate it? I'll tell you why I'm asking this later.
Okay. No, I tend to see our focus is to go on to the mandible as you're dissecting, so that you avoid it and you try and retract it.
Okay. Okay. So this was an issue which I discussed with some of my colleagues who do parotid surgeries. And they said, ideally, this is for the younger surgeons. They said, ideally, do not ligate the retromandibular vein, because if you ligate it a little lower, and then the consequent enlargement of the vein itself can cause some amount of transient palsy by putting pressure on the facial nerve. So this is a point of interest to the younger surgeons. So shall we move on to the questions that were asked by the
yes, please. Yes, please. We are running short of
time. Yeah. We have just another 5 minutes. Dr. Syed Saima has asked, please elaborate TMAP approach. The reference papers have been given in the slide. The slides will be shared with you, and you can see that. Is the deep subfacial approach reliable? I think we've answered that question. Dr. Abhay quoted Dr. Deepika's article, which will be put up. The latest modification in approaches of TMJ. I think this question Arun should take because he's done a lot of incision cases and with approach. And Arun, would you like to take this particular question?
Yeah, that is mainly used for ankylosis and condylar head fracture. It cannot deal with neck fractures. So it is a modification of endural approach where we make the incision a little bit posterior to the tragus. It's mainly cosmetic because your scar is less visible. It is a relatively easy approach because all you are going to go just deep below the every plane, right? Skin and then cartilage. You go in between the skin
What
and the
about the
cartilage.
nerve?
Nerve, everything will come in the flap envelope.
Okay. So you
Because
feel
it's
this
going to
is
be
anatomically a safer way of doing.
safer way once you're on the right plane.
Thank you
Except
so much.
there is a fear about exposure, but I get good exposure. Even coronadectomy I've done with this exposure. So
Fantastic.
it is a safe approach. Yeah.
Thank you, Dr. Arun. So we have a question here with, I think Dr. Muthusekar would be the person with his vast experience to take it. Sir, if there is a tumor on the temporomandibular joint, I am assuming it's an osteochondroma or benign tumor. Which approach would be beneficial, sir, in your experience?
Tumor of the
temporomandibular joint. So here the Dr. Reddy hasn't specified which tumor. I'm assuming that it is benign. So if there's a tumor on the temporomandibular joint, which approach is beneficial, sir?
Preauricular only, of course,
Preauricular.
extended preauricular incision.
Extended
Depends on the preauricular, extended preauricular incision.
Okay, we have an interesting question from Dr. Ali, which I'm going to ask Dr. Chitra to take. If facial nerve injury happens, what are the measures you should take post-operative? And he requests us to answer from our experiences.
And thankfully, I have not had any facial nerve, permanent facial nerve damage.
Okay. How long would you wait, madam, before classifying?
Do you want me to take that, Satish?
Yes,
Sure,
yes,
sure.
please.
All of you.
Please
All
go
of you.
ahead.
I think each of our experiences will be different.
So this is, Dr. Just to address specifically, because you said experience. When we are doing transparotid, we tend to see branches coming through. And when you're dissecting through the parotid, it tends to ooze a little bit more. Whereas when you're doing parotid, you're doing a bigger incision, you're going all around and you are more aware and you go a bit more protected. When you're doing transparotid, it's a small area, you're focusing and the nerve is lying somewhere in between. Whatever we have found is if you see the nerve, you're more careful all around because you don't retract that nerve that much. The rest of the area you can retract and you know the plane where the nerve is coming. Everywhere else you can cut comfortably. If you don't,
I would like to add on to that.
Yeah.
So what I do is anything below the capsule, I bipolar. I don't use anything else. I use either my bipolar or what I do is, and what I do is I ask my assistant only to use a copper malleable. The amount of force that you can use on a copper malleable is far less.
Not much, yeah.
What you could use on, and it works well for me. Whatever I don't do any retroparotid or anterior parotid. So most of all my cases are transparotid, and this tends to work really.
Having said that, I've held the cord nerve, one of the branches with the cautery. As you speak to the assistant and hold on, they think it's not on. So you can do, but as long as you don't cut it fully, the nerve will recover.
Yeah, it all comes back. My only problem has been with temporal branch. Some of my cases, as long as I follow up the patient, it hasn't really come back. 2 cases of mine. Most of the other things come back. So what about your experience with that, panelists?
In a basic setup, a blunt dissection is all the more you need to get into the parotid. You avoid cutting or transecting any nerve. All you do is a blunt dissection, go through the nerve, just retract gently, and you will endure the masseter. Once you are into the masseter, onto the masseter, you can use whatever instrument and then get to the bone. That is what I do. Once you are below the capsule, use a blunt dissection. Just use the artery forceps to do a blunt dissection parallel to the nerve. That avoids nerve injury.
Satish,
I have a question.
Satish, the question we have not addressed Dr. Raza's question. Question is, what will you do? The damage is there. So it's there. We wait for some time unless otherwise we know that we have definitely transected if you have valid. If not,
so I would wait for about 18 months. I would wait for about 18 months to 2 years with all conservative methods, including physiotherapy and whatever. And worst case scenario, luckily I haven't reached that position, but one of my colleagues has reconstructed using the greater auricular and it's worked well for the eye branch. So
you
happens.
when you know if you have definitely damaged it, you can go in earlier because you know it's not going to recover. And
yeah, like you mentioned before,
and
and Marun mentioned before, the chances of you seeing the naked nerve are very less. So especially when you're opening temporomandibular joint for routine procedures, it's not like you're doing a parotid where you're actually trying to find the nerve and dissecting on the nerve. So the chances of protecting the nerve also becomes that much more
so the
difficult.
most
I feel
important,
when you don't see where it is.
yeah, the most important thing when we are waiting is give protective measures like eye protection and reassure the patient, and maybe some medications like.
And I think
You don't know how much they contribute.
Sir told in the beginning,
Neurobion.
Anatomy is very, 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 very.
No,
you need to
Satish,
know your
it has-
anatomy on
Satish,
fingertips. Yeah.
This has happened. We
Yeah.
have discussed this. We are trying to say once it has happened, what to do next.
What
That's
happened?
the question.
Yeah.
So that is what we are trying to address now. So it has
Yeah.
happened. So we wait till it
You wait.
recovers. Give it time.
Yeah, I think
the
evidence-based
meantime-
literature says 8 to 18 months.
In as we are waiting, we give them specific instructions for physiotherapy, eye protection,
Yes.
and general advice,
Methylcobalamin.
reassurance. Yeah, and then also medication, B complex, B12 may help, but it is mostly a supportive medication. It's not definitive because nerves, B complex is good for nerves. You
Yes.
can give it. But remember, a motor nerve just like that doesn't heal because you're giving B complex. You're hoping for it to come back.
I have a question from Dr. Venkata Salapati. He asks indication for reopening of surgical site. I don't think this question, sir, is relevant to our particular discussion today. Kannan, what do you feel?
Indication to reopen for
Reopening of surgical site. For what? He hasn't specified. So, sir, we will wait. If you could just elaborate on that question.
No, one good thing is if your first surgery is good, meaning you have not caused any complication, you just follow the same scar pathway. You will be fine. It will be a little bit tougher, but you go through the same thing and without being over.
There will be some amount of fibrosis.
Yes,
that's going to trouble you.
Yeah. Pardon?
So we have a question here, which I'm going to ask Dr. Jagdish. This is from Dr. Rizwan. Is there any change in tongue position after interpositional arthroplasty?
I didn't hear the question. What is the question?
Yes. Is there any change in tongue position after interpositional arthroplasty?
I suppose they are meaning for TMJ ankylosis, and if and I think it will have a bearing only if you're going to increase the length, the height of the mandible.
Height of the mandible.
If you're not going to increase the ramus height, there is not going to be much. So if you're going to increase the ramus height, tongue is going to follow the mandible.
I think that I think we've answered most of the questions. The other questions have been answered during the lecture itself, so we are not going to go into it. Let me take this opportunity to, we have one last question from Dr. Ali Reza. Is there any role of early start of steroids after post-operative facial nerve damage? So,
yes, that is there. Any nerve damage?
It is.
What would be your choice of steroid? Prednisolone?
Yeah,
prednisolone.
Yeah, methylprednisolone.
Absolutely.
And I think it would be beneficial for our young listeners to know about the dose. What doses would the panelists prefer, and for how long? We are assuming that it's oral prednisone. So, hello.
Is someone saying or?
So you can take the question.
I know steroids we start. So when you're saying facial nerve damage, so immediate post-op, you see the patient in recovery. There is a little bit of swelling. You know immediately there's going to be any facial nerve weakness or not. So if there is no weakness, but you know your retraction is more or there is manipulation, we don't start on prednisolone. We go with 3 days of injection of dexamethasone is fine because we are just minimizing the swelling. We don't want the swelling to cause some injury to the nerve. But if you see clear-cut facial nerve damage there, you can see with the eye not moving well, or when they're smiling, it's not moving as comfortably. Partly pain, partly eye closure is a definite indication. And if it's fully open, then yeah, methylpred. Methylpred, though the basic dose is 20 mg, we may tend to go in more. Hit the more if it allows. so that to cut it down.
Thank you so
Whereas DEX, we will go with 8 mg.
Yeah, I
So
think
2
8
days
MB,
IV
380,
and
3 days
stop.
is gold standard.
So if not, if we are showing definite greater damage, then probably it's more, and then we will go for a week of methylprednisolone and then try and take it beyond the 2 weeks taper.
So what would be the dose that you would use? Would you use a loading dose, or you would go with the standard dose?
One 500 mg loading start, and then
Okay.
20 mg steady.
Okay. Are there any other panelists who use other protocols for facial nerve palsy, steroids with relation to facial nerve palsy post-operative?
I prefer to use dexamethasone 8 mg actually injectable.
We also use dexamethasone.
Dexamethasone. But what about long term? Like suppose you can't use Dexa for so too long. No? Suppose you want a dose with prednisolone. What would be?
I would probably give a loading dose and then maintain.
the same thing.
More than
I
2
think-
weeks, I don't think steroids will help.
Helps.
Yeah. Yeah. So I think that answers all our questions. I think thank you so much, panelists. It's been an honor and a great learning curve for me. Dr. Kannan, Dr. Abhay, Dr. Chitra, Dr. Jagdish, my teacher, mentor, without whom I wouldn't be here, Dr. Muthusekar and Dr. Arun. So it's been a privilege moderating this session. My apologies if I ran short on your expectations. I'm handing it over
Satish,
to-
you don't need to be apologetic. It was nice. Each one has
very nice.
You have your style. Thank you very much for
Thank you so
kickstarting
much.
the series, Dr. Satish, and the moderators, especially Dr. Muthusekar, Dr. Jagdish, Dr. Chitra, and dear good friend Arun. So we will use him as and when we need. So Arun always tells good things about me, and I've never told anything about him. So at least as the secretary of the association, I'm being differential to it.
Good that if you don't say anything bad about me, that's fine.
Yeah. So we have a
So,
last
and
couple
before-
of minutes.
And before I wind up, let me also take this opportunity to introduce the co-mentor, Dr. Abhay Kamath, so who will add, along with Neil Patel, if he's not joining. But just to bring to the audience's attention that this is going to be a series of webinars. I'm sure Dr. Jimson would have told it in the beginning. A series of webinars tailored at TMJ. So your feedback is essential. Please, now the feedback will be live soon now. So please fill in the feedback and give it to get certificate. And a big thanks to Balaji Dental College for facilitating this webinars. Guardian, who are TMJ replacement guys, for supporting the webinar. And also ISTMJS and the Tamil Nadu Association. Both Dr. Abhay and Dr. Arun are there, who are representatives of the same. Thanks for endorsing the webinar, and the audience, most importantly,
Thank you, Colonel.
supporting it. And please come in for. So this is going to be the last Sunday of every month for the next 10 months or so.
Thanks.
Satish,
a lot.
it's again yours. So.
Thank you, Dr. Kannan. Over to Dr. Jimson.
Anytime for TMJ, I'm welcome. I'll be there. Thank you. Thank you all.
I think it was a fantastic
Thank
panel.
you.
Thank you, Dr. Satish.
Thank you.
so much.
Dr.
Good
I
afternoon.
think, we'll just hand it over to Dr. Jimson for last few words, and then we'll close.
Jimson,
Thank you so much.
Jimson, you
Yes.
can have like Bahubali or like PS1-2, you can have TMJ some 25 and put Abhay Kamath as only solo performer, and it won't finish. Maybe 1,000 years later, they will still come and find there is something like webinar and one person is still talking. Abhay there.
Abhay just left, I guess. Yeah, thank you. And thank all the mentors, panelists, moderator, and everybody for this fantastic program. And we had a very good participation, and I'm sure there is a lot of take-home message from them, for them. And at this point in time, I would like to just speak a couple of words about the forthcoming 16th Asian Congress of Oral Maxillofacial Surgery, which is going to be held next year. There are a few questions, few inquiries already saying that, sir, we have just sent the first call notice, and the conference is in July 2023. For your information, it is in 2024, next July. And we have already started the registration. So you can visit www.acons2024.com for more details. And this conference is coming to India after 22 years. The first one was in Mumbai. I think it was in 2002, if I remember right. And the venue is going to be the Chennai Convention and Trade Center. So we look forward to your participation, and you can be rest assured that all the postgraduates will get an opportunity to present a paper or a poster. The delegates will get an opportunity to present a paper or a poster in an international congress in our very own country. And there are much more interesting sessions are being planned. We have quiz, we have innovation sessions, we have next gen session, so on and so forth. So you can visit our website www.acomps2024.com for more details. And if you require any clarification, reach out to us, and we'll be glad to help you in registration and in your participation. Thank you. Over to you, Kannan.
Jimson, there's quite a few saying feedback form is not working or not not working, not opening, or not accepting responses. There's about 8 to 10 messages shooting up. Not able to fill, or not opening, or not accepting. So that's being addressed to people. So not to worry. And if there's nothing else from the panelists, we will wind down, and we will see you all in June, the last Sunday in June.
Thank you, everybody. Been a pleasure.
Thank you.
Feel free to message
Thank
us.
everyone, and Satish, it was quite a good presentation. Thanks.
Thank you.
Thank you.
Thank you. Thank you, one and all.
It is sorted out. The feedback is sorted out.
Oh, okay. Thanks.
Dr. Kannan, should we wait for a couple of minutes to see whether it's working so they can chat with us on?
Yeah, we are waiting anyway. Before we are going, we will be more than we'll be more than happy if you are going to do also.
Okay. So since the feedback there,
Is Dr. Sushant Shoni there? There is a raised hand. Sushant Soni and Balaji from the attendees. Working now. Thank you. Thank you, guys. Thanks, Dr. Balaji, for saying.
I think
Thank you. Thank you, Jim.
Thanks.
thank you, everybody. Thank you, Jimson, sir, for the opportunity.
Congrats, Jim, for another great start to another series of web series. All the best, Jim.
And,
Thank you.
Thank you.
Thank you, Dr. Jimson.
thank you.
Pleasure
Thank you,
being here.
Dr. Jimson.
Thank you. Thanks for taking your time off and preparing and doing this fantastic webinar.
So
Thank
we
you.
will see
And,
the panelists for the next one as well. And please spread the message and remind people around in the last week of June to encourage them to participate in the next one.
Yes.
Yes.